Hello and welcome to Niaga Spotlight with me, Tamina Kausji. Niaga Spotlight takes us through the week in economic analysis and future affairs. Now, this week on analysis, we discuss addressing depopulation, fertility after 40. Now, depopulation and demographic shifts are a topic of global economic conversations in 2025. In much of the world, fertility rates have fallen below the replacement rate required to maintain a stable population, and despite increasing longevity, some countries have already started to see population decline. Others may follow in the not-so-distant future. Now, in Malaysia, the total fertility rate, or the TFR, has declined to 1.7 births per woman in 2020, the lowest in over 4 decades, and below the replacement level of 2.1 children per woman. Meanwhile, mothers aged 30 to 39 years recorded the highest live births in the first quarter of 2024, i.e. 55,864 births, which accounts for 52.5% of all births, while mothers aged 40 years and over during the same commensurate period recorded 6,383 births, or 6.0% of overall births then. Now, this trend is influenced by socioeconomic factors such as increased educational attainment and career focus among women, leading to delayed marriage and childbearing. At the same time, increased financial security and social mobility in the 40s is a reason pregnancies and childbearing among women and couples above 40 is also on the rise. Additionally, Malaysia does have a high non-communicable disease or NCD burden among adults, particularly in the 40-plus demographic, linked to, of course, lifestyle factors that are clearly documented: poor diet, sedentary behavior, smoking. Now, these health issues, along with economic pressures and delayed childbearing, contribute to an overall lower fertility rate as older adults face health-related challenges. Niaga Spotlight today focuses on key issues and strategies that are in place to improve fertility after 40 in order to support sustainable demographic and economic development in Malaysia. It's an absolute pleasure to welcome today to the studios Dr. Gayatri Mariappa, consultant obstetrician, gynecologist and maternal fetal medicine specialist with Sunway Medical Center Velocity, SMCV, joined by Dr. Ashley Cheong Subi, consultant obstetrician, gynecologist and fertility specialist, also with SMCV. A very good morning, doctors. How are you today?
Very good morning to you.
Very good morning, everybody.
Yes.
Fantastic. Thanks so much for being here today. So perhaps I could get the ball rolling by asking Dr. Gayatri in particular. So, of course, we do know that the scenario right now is looking like there is a very unique intersection of increasing fertility among women over 40. At the same time, we have a high prevalence of all the NCDs, which are constantly a topic of discussion in Malaysia. Yeah. Dr. Gayatri, a couple of insights from you, beginning with looking at maternal and fetal health risks when we combine these two together, despite the fact that we are seeing some positives and some upticks in fertility after 40.
Okay. Excellent question to kickstart our discussion today.
Okay.
So we know that women 40 years and older, they fall in this special group of population where they are more likely to have or already have coexisting medical conditions, like rightly you said, non-communicable disease are in the higher trend among people aged 40 and above. Mm-hmm. So non-communicable disease here would be diabetes mellitus, high blood pressure, hypertension,
that's right,
obesity, and of course Malaysia is known as the obese country in Southeast Asia. We have heart diseases, kidney diseases. So when these women with these inherent risk factors go on to embark on the pregnancy, that increases their risk more on regarding the pregnancy outcomes. So they tend to have higher risk of pregnancy-related complications, such as, firstly, difficulty conceiving,
right, in the first place.
In the first place itself, yes.
Yeah, that's right.
Then they will have there's a risk of miscarriages, pregnancies affected with babies with chromosomal or genetic problems, diabetes, high blood pressure, which is pregnancy-related, a condition called preeclampsia, having risk of blood clots, which are thrombotic events, which can be life-threatening. As they go on through the pregnancy, cesarean sections are higher, risk of bleeding during delivery is higher, and even requiring ICU admissions. So it's just not, I mean, you can get pregnant, but there are the risks that we need to be aware. So how do we better this and improve these healthcare aspects would be, these women would benefit so much from what we call a pre-conception counselling, or also known as pre-pregnancy counselling. So what is pre-pregnancy counselling? It is when they have a sitting down, a discussion, best done by with a maternal fetal medicine specialist or someone who is trained in high risk obstetrics. All right, we have a discussion on what is their coexisting medical conditions. How do you optimize before you get pregnant? What are the screening tests can be done? Just let's take diabetes for an example.
Exactly. Now, of course, when we're looking at our NCDs, over 50% of adults in general do have a pre-existing NCD. Diabetes might be one of them.
Yeah.
So on average, let's say, are you actually seeing lots more women who are in their 40s or close to their 40s actually coming in for these preconception consultations, doctor?
We are starting to see a trend that women are taking,
Right.
they're empowering, we have empowered them. There's awareness there,
Yes.
but I think we still need to further increase. But there are women coming in, I want to get pregnant, I have diabetes, so how do I go about it?
Right, exactly. So being aware, so that's the first step, right?
Correct.
So once they're in that preconception consultation, what happens next in the road towards ensuring that you become pregnant and then, of course, are able to maintain a healthy pregnancy? Very briefly.
Okay, so very briefly, so just say in diabetes, so we want to ensure they have a good glycemic control,
Right.
looking through their medications, the tablets they take or the insulin regimes, going through screening for any target organ damages, because we know diabetes is just not about the sugar control, but looking at it can affect the kidneys, it can affect the eyes, it can affect your heart. So, because when you get pregnant, if you have already this additional organ damages, they get accelerated during pregnancy. So it's best to optimize all this, work together with our other consultants such as the endocrinologists or cardiologists to have so that we can sit and have a holistic care together on managing the woman. And she's aware before getting pregnant.
That's right, exactly. Thanks very much for that great introduction to the entire topic, Dr. Gayatri. Now, digging a little bit deeper, Dr. Ashley, so I'd love to ask you about looking at Malaysia's healthcare system overall and also adapting fertility and pregnancy care models to be best able to serve looking at hormonal disorders among women, especially those above 40. Tell us a little bit about your experiences working with this target group.
All right, thank you for the questions. I mean, Dr. Gayatri has elaborated quite a understanding about what we have to know. As women, that that nowadays, working women, we are in dilemma whether family come first or our career advancement first. So
Sure.
looking into that, we know that now we have working women that want to set up their family a bit later. Maybe they want to have more financially stable and then have more better support in terms of families and friends and peers around. So first of all, we want them to know, the awareness of what is a hormonal condition, like for example, PCOS, we know as polycystic ovarian syndrome, which is quite commonly seen in our fertility fields. So sometimes some ladies, they might not be aware that they have condition like PCOS, or they don't even know that they actually have a coexisting problem like diabetes, hypertension. They might think that, oh, this could be stress related or things like that. So awareness, I think early screening is also important. So if you already have the mindset of setting a family after you get married, like for example, if you are below 35 years old and probably you want to set up family a bit later, maybe up after 35, maybe have a screening done with your partner. So I would always encourage that couples come together. Okay, we always screen couples together to make sure that they are in good health. And then we screen the husband to make sure that the sperm quality and sperm quantity are at par. And then we look at a holistic condition to see whether do they have any medical problems that they want to target, or stabilize their medical issues. Like, for example, if they have some medical condition like diabetes, like even epilepsy on medication, or even they have some hypertension that need to be more controlled so that they won't affect the sperm quality or what we call as the eggs quality.
Or the potential pregnancy in the near future. Now, it's very encouraging to hear actually that these days you actually have couples coming in together and not just the women. When did you see this shift happen? Perhaps if you're able to share with us on a timeline, and now it is taken as more of a family decision, a couple's decision, rather than the responsibility going completely on the woman to manage fertility.
I think we are doing quite well in, getting all the couples out there to know that if they are less than 35 years old and they try to conceive more than a year, they should actually have a check to make sure that everything goes in the correct directions. And those women who are trying to conceive after 35 years old, if they are trying more than 6 months, then we will encourage them to walk forwards to have a check. So I think after what we call the COVID MCO, and then everyone do have a lot of awareness on social medias and all.
Sure.
So I think after after MCO, and we can see that the trend that they are always, they come together and they know the importance of coming together and give support to each other as a husband and wife. So as a couple, we would say that the support among them is important. All right. Okay. We would say that problem would not always happen just from the women's side. Okay, we want to know, yes, ovulation, part of it, how is it? We want to know the uterus condition, ovaries condition, and want to see some normal bloods investigation to see is there any deviation. So usually we do a bedside scan in my clinic, and we're going to assess the general condition of uterus and ovaries. At the same time, we also would want to see the sperm analysis that we can be done in our one-stop center in SMCV.
Right. So a one-stop center, I think that actually makes things so much easier to manage from a personalized and specialized pregnancy as well as pre-pregnancy monitoring, right?
Yes. So a personalized fertility care is very important. So we look at a holistic condition where not only fertility issues, but we go into their comorbidities and the possible implication if they get pregnant a bit later, like what we say after 40. So what we say that it's not a taboo to get pregnant after 40. I think it's now we see more and more mothers they are bearing child and giving birth after 40.
That's right.
With a very specialized share care with our maternal fetal medicine specialists, with other endocrinologists, and with tertiary hospital deliveries and care. I mean, we are doing quite well on that. So just that we need the awareness and we need to investigate. We need to detect early, and the antenatal care, postnatal, and the most important, the pre-pregnancy care to stabilize and to make sure that everything is at par before we embark on the pregnancy.
And of course also in the process reducing miscarriage as well as fetal development risks which naturally come with age. Thanks for that, Dr. Ashley. So moving from there back to Dr. Gayatri. Now looking at Malaysia within the context of the fact that we are a most multicultural society, so how do you feel healthcare providers can actually then especially tailor maternal care strategies for women over 40 to address perhaps culturally specific barriers? We're talking things like dietary practices, family structures, even access to care, which on an individual basis might actually form a barrier.
Okay. Perfect. So we do live in a very, like what you say, multicultural, various ethnicities. And let's talk about diet first. We have excellent, delicious food from north, south, east, west.
Absolutely.
All right. And so, I mean, if telling a woman, she's been eating all her life staple, traditional food, and saying that you need to switch to a very healthy diet overnight, it's not going to be easy. So looking just at the households. So in the Malay households, we know that the diet used to tend to be more rice heavy with gravy. The Chinese have more noodles and soup. Indians more spicy, more oily. So, but if we can, tailor fit the diet alongside working with our excellent dietitians that we have, looking at the Malaysian staple diet and trying to, maybe reduce, portion control. There's portion control, trying to look at food which have low glycemic index. So glycemic index are the ones, are the sugar content. So especially for women with diabetes and all, we want to have a lower glycemic index. And doing that, you get more, the compliance and trying to change your diet gets healthier because, I mean, frankly, going for extremely healthy or a keto that, there's so much about it, it's not cheap.
Exactly. Yeah, but at the same time, I think it would actually be about whether or not that could be adapted to the daily life, right?
Exactly.
Yeah, because I've also heard actually, firsthand from friends who are also trying to conceive in their 40s that they've actually been advised against going completely 100% opposite to what their diet used to be, right?
Yes.
Would that be accurate as well? Because you can't, you've got to slightly walk a middle path when it comes to environmental and dietary factors?
Yes, I think that we have to find a balance in everything. So, knowing what you can and what you should avoid. One is healthy diet. Then it's your making sure that your supplements are up to date, your folic acid, your vitamin D, and then your lifestyle. Healthy lifestyle goes hand in hand, reducing alcohol intake or stopping alcohol and smoking. So all this come together. So that's in terms of diet.
Sure. And perhaps when it comes to those who are perhaps not in the demographic where they're able to come in for personalized healthcare plans, a couple of thoughts on looking at maybe community health programs, which could then prove of value to actually address the diverse needs of older pregnant women who may not necessarily come under the medical specialist demographic.
Yeah, I think like even in at SMCV, we do have programs, for healthier lifestyle, healthy diet programs, which work hand in hand with our endocrinologist and our dietitian.
Right.
So they have that very catered for a special group of demographic, like rightly you mentioned. So that will help us guide on how we can better their lifestyle and diet. Yeah.
Absolutely. Thanks for that. Dr. Ashley, I actually wanted to go and dig a little deeper into looking at specific occurrences of endometriosis and fibroids among women in Malaysia and how this actually needs to be under preconception care if women over 40 intend to conceive.
Okay, we do see nowadays, we do see more and more women who step forwards to saying that, doctor, I want to check for fibroids, I want to check for endometriosis and all that. So they are aware of what is fibroid and what is endometriosis nowadays.
Right.
So we know that now public are well aware. Okay, they have this condition that might affect their fertility. So we can see that there's more gynecological routine checkup every year, or even they come in, just drop by, they say, I plan to get married soon. So I just want to check whether am I okay? Is my uterus healthy? Are my ovaries okay? And things like that. So I would say awareness is a very good thing that we are actually promoting nowadays. All right. So I think women out there, if they are in their working life and all that, they know what is going on. All right. Secondly, is early detection of whether you have fibroids or you have endometriosis. So symptoms is also important. So when we say awareness, then they will actually know what symptoms they might have. Like, for example, they have severe pain during periods, or they have bloatedness, they have enlargement in their tummy. They feel that, oh,
right,
maybe my pants is getting tighter. There's something maybe I need to be aware instead of thinking I'm fat.
Yeah, so just actually being in tune.
Yes, being in
and
tune.
I think it's an interesting intersection, and I'd like to just bring up this topic organically as well, because also around your late 30s, early 40s, there is, of course, a demographic of women who may already be experiencing perimenopause symptoms.
Yes.
So when that actually colludes with the fact that they are also perhaps trying to conceive, how do you then, get the right kind of advice medically, but also check yourself so that you are sure or you're able to identify is what you're going through perimenopause, or is it, just hormonally related?
All right. Yeah. So first of all, we will do a basic ultrasound scan. All right. We will, if you're sexually active and you're married, we advise to scan from down below. We will call it as the transvaginal scan, so
right,
that to let us assess your ovarian functions, the follicles that we're going to see, and also the structure of the uterus. So in another hand, we also have some blood tests, like for example, like anti-Mullerian hormone, what we say as AMH, to assess the reserve of your ovary. And we know that when our age advances, the AMH level will get lower, and that will reduce the chances that we get pregnant. So if you get to screen all this beforehand and you know the chances that you get pregnant, and we know that maybe we can put in a bit more effort to help in terms of fertility. For example, we can suggest a IUI or even IVF to help to get you pregnant and embark in a pregnancy in a more planned and proper way. Yeah, so like some patients may ask, doctor, do I need to take out my fibroid, or do I need to do surgery on the endometriosis so that I can have a higher chance to get pregnant? I would say not all cases that we need to get you into the operation theatre. All right. So I would say personalized care a holistic care, and we individualize plan. So maybe your fibroid is about maybe 6-7 centimeter that obstructing, the cavity, or maybe will reduce the chance of fertility, or you have symptoms like you have severe pain that you can't go to work every month when you have your periods and all that. The quality of life is not there. I would say the quality of life is so important before you embark in the pregnancy. So that will probably we go for surgery before you go towards your pregnancy care and so on after that. Because we know that fibroid in pregnancy also carries a risk in your antenatal development of the baby.
Exactly. So and there are also other associated risks like placental insufficiency, obstructed labor during pregnancy. So when you are actually part of a management plan, so this will be all covered under that.
Yes, exactly.
That's correct. Yeah, because like I mean, you're saying placental insufficiency. I mean, that is it can be a lot of factors. Like because not only structural, like fibroids and endometriosis, but the maternal health itself. Having underlying diabetes or high blood pressure or preeclampsia. So preeclampsia is this condition that we hope to get this awareness out there that it's it's a disease of the placenta. So the placenta is the afterbirth, that connects the baby to mom. So if you have a abnormal placentation from the start of the pregnancy, that puts you at risk, to have small babies, early deliveries, high blood pressure, can affect up to fluid collection, retention in the lungs, and even a seizure. So doing all this by screening early in the pregnancy, then knowing how things are, you can better plan and you intervene early by just
and particularly, of course, any stressors, particularly during a pregnancy, given the age factor of anyone who is over 40, then of course it multiplies, right?
Yes, correct, definitely.
All right.
Prevention is better than cure. So, of course, some supplements that actually come into point as well to prevent the severity of the disease.
And to manage it as well.
Yes.
Right. Well, thank you for the conversation so far. Most interesting, of course, but we'll take a short break. Don't go anywhere. We'll be right back with Niaga Spotlight, still discussing addressing depopulation via fertility over 40. See you. Welcome back to Niaga Spotlight, still with me, Tamina Kaustri, and today, of course, we're discussing addressing depopulation via fertility over 40. Dr. Gayatri, so now going back into some emerging best practices, though, looking at monitoring and managing fetal development in women over 40, let's look at environmental stressors and factors such as air quality and urbanization in particular. So this, of course, actually does play a part in whether or not pregnancies over 40 will actually be stable, successful, and of course result in a healthy outcome. Tell us more.
All right. So, so urbanization is when, that's what's happening here in this part of the world, in Malaysia. So when there's a lot of changes that happens in a woman's life, from work to going out and, being exposed to the outside world, there's a lot of things that we could try to adjust from lifestyle modification. What is lifestyle modification? It's not only purely dietary. It's going out, having a good, proper exercises, healthy exercises, making sure you're well and fit. And they also about air pollution. You're talking about exposure to so much of chemicals and smoke. So maybe we could consider limiting the time that you actually are on the outside, getting filters, or most important is smoking, exposure to secondhand smoking. So reduction of that could assist and help with those conditions.
Right, exactly. Dr. Ashley, in your perspective as well, particularly because you focused on more of a holistic outlook and also looking at couples who are trying to conceive, not just the women. What happens in the case of those who are actually within a domestic situation whereby you live with a smoker? So secondhand smoke is definitely a causation and a possible risk factor, right? How can that be addressed holistically?
All right. So like smoking, we know that it's very bad for general health, all right, your lungs, all right. So, but of course, we do see that patients who come with infertility, And we know that some of them have, you know, they are smoker or they are secondhand smoker, exposed to secondhand smokers. So we see the quality of their sperms reduce. All right, this in quality forms and in quantity of the sperm is reduced as well. So we see that smoking is one of the tremendous, what we say,
triggers, perhaps.
Culprit behind it. All right, we know that if we advise them to stop smoking or even reduce smoking, and even vaping actually do affect the quality of sperm. Patients who comes with some male infertility with some affection in the sperm qualities and quantity, we say you stop smoking for a few months and start with some supplements to enhance, supplements that contain zinc, selenium, all right, CoQ10, that some will actually try to improve the production and quality and quantity of sperm, and that will actually enhance the chances of getting pregnant as well.
And does that actually then, in your experience with cases that you worked on, then act as the push for either quitting or reduction?
Yes.
Because in a couple of months, you're able to see measurable outcomes,
yes,
right?
Yes, I do see in certain patients who they actually stop smoking and they improve their quality of life, they modify their lifestyle by, you know, if we say that in country, I mean in city like KL with stress at work, you know, unbalanced diet, you know, the timing of having their meals are actually disrupted. All this actually cause a lot of stress to your body. And this indirectly or directly actually affects the quality of gonads, irregardless sperm. Sometimes you know that the oocytes, the eggs that we retrieve during our IVF treatment, we do see that those patients who has a lot of stress with their, you know, unbalanced diet, with, you know, smokings and all that, it affects the quality of eggs and it affects the quality of embryo. And
so that's one part of the lifestyle factors arena.
Yeah.
Dr. Gayatri, asking you about looking at perhaps emerging best practices, and are we at this moment in Malaysia already incorporating any sort of remote or IoT-based monitoring solutions when it comes to high-risk pregnancies?
Okay, so yes, we are. We do have very good emerging best practices. So let's split into, because the pregnancy care used to be a pyramid. But now we have tend to have it an inverted pyramid, so where we give more importance at the early point of pregnancy, where, you know, from the first trimester, as early as looking, you know, having frequent follow-ups, scans, early screening. Why is it essential that the early you screen, you can intervene and you can re-stratify the pregnancy so that things go smoothly along the way. So, for example, for both, we don't only look at the baby, we look at mom and baby.
Right.
So firstly, again, with women more than 40 years old, they're at risk of having miscarriages. So knowing where the pregnancy is, and also they are 3 times more likely to have an ectopic pregnancy, which is pregnancy
3 times
outside.
more likely.
Yes, than a woman who is about
statistic.
20 to 25 years old. Yeah, that is worldwide statistics that says that. So knowing where the pregnancy is, that's in the womb, whether you can lead for a miscarriage, and that's what we do in the early scans. We also look at scanning the baby, where, you know, they say we do an NT scan looking at the fluid behind the neck of the baby. So these are all screening for chromosomal disorders for the baby. Besides that, what we also do is, like I mentioned, preeclampsia. How do we predict so early? Because this is a disease or condition that happens after 20 weeks, the second half of the pregnancy.
That's right.
But what can we do early is we do a Doppler ultrasound. So when we're scanning the baby, all I have to do is move to the side, look at the vessels that supplies the womb, and look at the flow. So if the resistance is high, then and then, you know, there are a lot of calculators, and, you know, we re-stratify and risk calculators to stratify, and we say, okay, this mom is at high risk, so we have to we start with a supplement called aspirin, not the painkillers that we have, but aspirin. Okay. The dose is about 100 milligram initially, then to 150 milligrams.
Right.
You take it daily at night, and that reduces your chance of preeclampsia by 82% by 34 weeks. So that is a big number, because...
Very significant,
yeah,
82%, all right.
Yeah, and you're talking about preterm delivery, small babies, because again, that comes into the economic front where, you know, having a baby in the neonatal ICU for not a week or 2, but sometimes some babies end up staying to 2 to 3 months.
That is a considerable financial drain on
Yes,
families.
correct. So just a medication can reduce that risk. So then we go on to screening throughout the pregnancy. So we know her risk, and it just say she has, then we screen for diabetes. If she never had a chance to attend a preconception counseling, we can take this opportunity to look for diabetes, any thyroid disorder. Usually they're hypothyroid, where their thyroid levels are lower, and then, you know, for any kidney disease, so that we can start medication early and treat. And then as the pregnancy goes, you know, you have close monitoring, looking at the baby's growth, looking at the mom, her blood pressure, her weight gain, and then for delivery.
Yeah.
But I think what I want to bring to the attention is, we know about practices during pregnancy, but the 4th trimester, which is the postpartum, is the most essential. So imagine having a new mother with a baby, struggling, you know, with breastfeeding, trying to lead a near to normal life, and you know, having a lot of mental stress from out there, and coping herself. So what does she do? She neglects her
own well-being.
Her own well-being is neglected. So, but that will have implications in later life, because if you have preeclampsia during pregnancy, you're at risk 4 times to have heart disease and hypertension later in life. Correct.
Understood.
So, as the healthcare professional, as a, you know, maternal fetal medicine, fertility consultants, obstetricians, we should try to continue her follow-up after delivery, and she have a transition over to her general practitioner, to the clinic kesihatan, or the, you know, like the endocrinologist or cardiologist. So there's an onward care. So I think the post-delivery follow-up and care is also very essential in these women. We can't just let go.
Thank you. Thanks very much for that, Dr. Gayatri. I love the fact that you emphasize on the 4th trimester per se. Dr. Ashley, anything to add to that, some perspectives?
I totally agree with her. I mean, I do see my post-delivery patients like up to 6 weeks. That means I do give appointment after that, because to check on them. Right, to check on them not only after delivery, looking at their ovaries, looking at their uterus and their wound or their scars, but the mental stress and the mental development they are going through, which is very important. So I will always have a small chat with them after deliveries. I mean, like in the clinic sessions, to check how are you coping with your breastfeeding, how are you coping with your babies and all that. Is there any issue with your babies that, you know, that we can help further, or do you have any problems with, you know, breastfeeding, or sometimes the milk supplementation, and sometimes diet-wise, and she feels that she has no attention to herself, she loses herself. And she has no confidence, and to get back to work is another stress for her.
Yes, postpartum depression as well, whether it can be identified on time, right?
Yes.
Absolutely. So Dr. Ashley, I'd like to go a little bit deeper into how actually, now we do have increasing recognition and awareness amongst the general public of fertility clinics as well as obstetricians. Now, how can it be all well integrated together as a system so that age-related infertility clients who are coming in, women and their husbands and couples, and integrating it into a comprehensive diagnostic approach, something that is perhaps streamlined across the country, especially given the risk factors that are quite commonly known for most Malaysians?
All right. So it's a very good question that we want everyone out there to know, that if you are trying to conceive, so first of all, you must know your body. All right, you must know what is going on. So early screening about any comorbidities like diabetes, hypertension, any thyroid issues, okay, that we need to address. All right. If you have abnormal uterine bleeding, if you have abnormal bleeding periods, prolonged bleeding and things like that, we need to check whether is your uterus doing good, whether is there any abnormal changes in the lining of the cell, or any abnormal condition of the ovaries that we can actually do a simple investigation like scans and some
the
blood
AMH
tests.
that you mentioned earlier.
Yes, some blood tests to assess the patients, male and female patients. All right, you come in a group, as a couple, and after that we will also, once we embark her in pregnancy, for example, if she is going through IVF. So we do have a lot of advanced technology to help us on this. We know that age is also another factor that contributes to abnormal fetus, abnormal babies in future. So we want to screen further. If let's say we go towards IVF treatment, so we do have certain investigation, for example, the pre-implantation genetic testing, where we can actually check on the embryo cells and to check whether is there any chromosome issues, like for example Down syndrome or any genetic disorder that carries in the family. Like for example, if both parents are thalassemia carrier, And we know that if, like, for example, both parents are thalassemia carrier, their babies has 25% of inherit what we call as major thalassemia, where the baby will be at a very high risk in future development.
It just basically helps facilitate informed decision making.
Yes,
perhaps.
yes,
Right.
yes. So we can know it earlier, even before you get conceived.
Sure.
So we can know whether if the baby has any issues, any chromosomal problems, any genetic disorder prior to conception. So we would have a testing on the embryos before we put the embryo back into the uterus for conception. So we might actually stop the hereditary line at that generation, like for example, thalassemia carrier.
With that advance, actually. Now, do you actually see couples taking that choice in some of the cases that you have dealt with?
Yes, we do have the perception that maybe like 40, 50 years ago, we say
Right.
that, okay, thalassemia carriers, you are not advisable to get married. Because
At
we
all,
don't want,
yeah.
we don't want
Correct.
that inheritance.
That's
in
no longer
future.
true today,
Yes, it's
right?
no longer
Yeah.
true. So, I mean, true love, who actually screen for thalassemia before you fall in love?
Sure,
No,
sure.
we don't. So, we do have couples who come in, you know, like alpha thalassemia carrier, both parents. I mean, like a beta thalassemia carrier. So, we want to screen. We want to screen. Even though some came in, they're already pregnant in their first or second trimester.
Right,
So,
understood.
thanks to Gayatri, I have her to help me with that, because we can screen the baby by doing an amniocentesis.
Diagnostic testing.
Yeah.
That's right. Yeah.
We take some fluids around the baby and check. And from there, we can actually prepare the parents of what are we looking at it next. What are the possible implications that we are looking at it, I mean, during antenatal and possible outcome after delivery. And we can get in our pediatrician colleagues to help us with counseling, with possible care after delivery.
Exactly. And perhaps this needs to actually be a consideration for those who are planning on starting their families later in life, regardless of whether or not they are already aware of genetic risk factors, right?
So I mean, adding on to this topic, so
Sure.
like you're mentioning about genetic conditions, about, you know, how they prepare. So when do these women actually, who do they seek when they come for treatment? We know women 40 and above have difficulty conceiving, or is their medical condition that makes them more susceptible to difficulty conceiving. So they might come straight to see a fertility consultant like Dr. Ashley, or they'll come to me, you know, to have a preconception. So working hand in hand and, you know, discussing what we can do at the very get-go is essential. Because you see, not everyone is going to go and say, you know what, I'm going to go and check myself with the doctors. And some women, we tend to, if we can't meet them in the preconception, we see them early in the pregnancy. So I think we should grab that opportunity to screen and intervene early. Again, early detection, screening, we intervene early for a better outcome for both mom and baby.
Exactly. So earlier as possible, but also perhaps even before people decide to get pregnant, right? Timeline-wise, what would be the appropriate timeline, Dr. Ashley, for couples who are planning at some point, but they know it's going to be at a later point in their lives that they will conceive, to start actually getting all your risk factors in line? That means looking at whether or not you're in an urbanized situation, what are your lifestyle risks, and how you can actually start working on them. What should the time frame be?
Okay, I wouldn't set a specific timeline, but I would suggest that if you are 35 and below and you are trying for at least a year, or you're planning maybe ahead later on, a year later, get yourself checked, just to make sure that everything in line before you are really embarked on your pregnancy. Like for example, if you have irregular periods, then maybe you want to know whether is there any issue with your ovaries, whether do you have any PCOS, whether do you have any ovarian cysts that hinder your regular periods, or if you have pain, you know, during periods, that we want to know whether you have endometriosis that we need to operate on. So if you have surgeries on your ovary, or especially on your uterus, we want to know when is the best time for you to conceive. Like for example, if you do have a fibroid surgery done on your uterus, so then we would say that the timeline to conceive may be 6 months or 1 year after the surgery. So that will be good for us to prepare you ahead.
Right.
At least a better contraception, instead of you get unplanned pregnancy and the possible outcome will be even more disastrous. So we want to prep beforehand. So if you're 35 and above, then we will know that the quality of eggs and the number of eggs will reduce tremendously. So we will want you to probably start yourself on some supplements, healthy lifestyle, some regular exercise, maybe some diet control with, reduce processed food. Those sweetened food will also cause aging advance faster. So we want you to get yourself more prepared. If let's say you're 35 and above, you're trying more than 6 months or about 6 months, please get yourself checked just to make sure that everything is in line.
Absolutely. And perhaps just before we end out, Dr. Gayatri, I'd love for you to perhaps share with us a little bit on your perspectives on the term which is quite common for pregnancies above 35, which is geriatric pregnancies, and how hopefully we can move beyond the stigma of getting and becoming pregnant and having a healthy pregnancy later in our lives.
Okay, I think that's an excellent question, how to, sum all what we are discussing today.
Sure.
So I think geriatric pregnancy, it's not a very nice term. And we should not stigmatize these women. We should have normalized this conversation. Make the woman feel comfortable before she's pregnant or during pregnant. It's not nice to say, hey, you're already 45, you want to get pregnant now, how are you going to run after your children when you're 50? That's not nice. It's her choice. But it goes back to that we have done the counseling, we have discussed together with the patient. It's a shared decision, and she's aware that, embarking on a pregnancy after 40, there are risks, like I mentioned earlier, difficulty conceiving, miscarriages, your diabetes, high blood pressure. And she's aware of all those risks, and she makes an informed decision.
And you've been screened and you're managing
we
your
plan
condition.
and we do a proper planning. We as the doctors should support and ensure that mom and baby have a safe and successful pregnancy outcome.
Absolutely. Dr. Ashley, any last thoughts on destigmatizing pregnancies and fertility above 40 as well?
Yeah, I agree with Dr. Gayatri. You have to remember that you are not alone. You are not alone carry your baby at 40 or after 40. So we are always here to help to make sure that you are a healthy mother, because we want to have healthy baby. All right. So a healthy mother means that we want you to be taken care properly. We want everything to be at par. If you have any condition, we want it to screen early and we'll treat early. All right. So prevention is always better than cure. So we are all here, hand in hand, multidisciplinary approach, shared care, and we know that everything will be much better. And the most important thing is healthy mother, healthy baby.
Healthy mother, healthy baby, indeed. Yes. Thank you so much. It's been a very interesting conversation, and of course I think it helps re-emphasize that not just early intervention, but hopefully positive outcomes, and looking at the statistics and demographics that we have of, women over 40 delivering 6.0% of live births in the first half of 2024. Perhaps with less stigma and more support and more awareness, we can push up that figure to even a 10%. And that will definitely help with looking at addressing depopulation and more. Thank you very much, Dr. Gayatri. Thank you very much, Dr.
Thank you very much.
Thank you.
Well, that's all we have time for today on Niaga Spotlight. I'm Tamina Kalji, and we'll be back next Friday with more economic analysis and insights. Here's to a productive week ahead.